what happened subsequently was a phenomenal progress in the field of cellular transplantation, as I would like to call it. It's a cellular transplantation. And uh, how we changed from using bone marrow to mobilized peripheral blood stem cells is another fascinating journey. How we ended up using cord blood as another source of hematopoietic stem cell is another fascinating journey. So now we have three sources of hematopoietic stem cells: the bone marrow itself, mobilized peripheral blood, and cord blood. But what happened in the early 70s, I mean, through the 70s and 80s, was that a lot of people, those who engrafted, those who were free of disease, died of something that was described at that time as interstitial pneumonia, which later on autopsy was understood to be cytomegalovirus infection and disease. Now, the cytomegalovirus infection accounted for 50% of the deaths at that time. And again, this is a beautiful tale in how understanding, diagnosis, and management of an infectious disease has changed the complete scenario of transplantation. Right now, the mortality from CMV disease is, in the worst case scenario, less than 5% of patients who go on to reactivate CMV developed by CMV disease if they're properly monitored and treated, and more than 50% of those survive. And compare this with what was happening when Donald Thomas established this discipline and struggled to keep patients alive for 2 decades. So with the improved treatment of CMV and new sources of graft, the scenario for allogeneic transplantation changed completely. And the other paradigm, I mean, what I called is there have been 4 paradigms which shifted in the field of transplantation. As you know, a paradigm shift is a change or a movement in our thought process from one block to the other. The first shift was when Donald Thomas, through a series of canine experiments, established that you need HLA matching to achieve engraftment. And you have to give something as GVHD prophylaxis for the patients to survive. The second paradigm shift was understanding that in order for patients to survive, you have to take care of a whole host of viral reactivations, the primary of which was cytomegalovirus. And subsequently, Epstein-Barr virus was recognized as a major nuisance and taken care of, and adenovirus, which took a longer time, and I'll come to it at some subsequent stage if people are interested in the course of our tutorials. But a major paradigm shift was in the mid-90s. Until that time, what we all thought, believed, and was staunchly entrenched in our transplant education was that we need to ablate the marrow. We need to give high dose of chemotherapy and radiotherapy to enable the donor marrow to engraft. And that resulted in 2 things. One is it resulted in a constant transplant-related mortality due to regimen-related toxicity, whether it's busulfan, whether it's cyclophosphamide, whether it's TBI, constant TRM, just because of regimen-related toxicity in the range of 15 to 20%, and especially when we were going to transplant older people. And to a large extent in the sort of early 90s, it was believed that if you're going to use those protocols in people above the age of 60, it's going to be detrimental. Now, there were 2 people who worked simultaneously in animal models. One was Shimon Slavin, and the other was Megan Sykes. They both, in their own ways, in Israel and US, established in animal models, or largely mice models, that you actually don't need to ablate a bone marrow for donor cells to engraft. If you immunosuppress them sufficiently for long enough, you can actually engraft donor cells without ablating the marrow. And this gave rise to the concept of reduced intensity or non-myeloablative transplantation. This was first shown in clinic by Shimon Slavin from Israel in, I think, 20 odd patients where he used half dose of busulfan with fludarabine, showing excellent results. Now, I happened to be there in the UK when this paradigm shift had started. And I was fortunate enough to be a part of this paradigm shift and contributing to it effectively. And now we know that non-myeloablative conditioning as well as reduced intensity conditioning being subject by itself is an established way of doing transplantation. But what I showed you earlier was a photograph of Hansi Kohl, who is, again, one of my gurus in transplantation, not direct. I am Ekalavya and they are Dronacharya for me, both Donald Thomas as well as Hansi Kohl. Although I had many interactions with Hansi Kohl during my stay in the UK, personally and over other forms of communication, I never had the fortune to interact with Donald Thomas. But what I learned from Hansi Kohl was fascinating, that adoptive immunotherapy is the crux of allogeneic transplantation for leukemia, especially when you're doing high-risk diseases. And that conviction, which came out of my interactions with him, helped me in establishing the adoptive immunotherapy protocol for haploidentical transplantation, along with Dr. Sarita, which is now widely published. We have now over 20 publications in this field. And I owe it to, a huge extent to Hansi Kohl, who first pioneered the use of donor lymphocyte infusion. And his canine experiments which actually taught me how to use DLI other than just giving some lymphocytes from the donor when a patient is relapsing or relapsed.